On-the-scene video coverage of AHA 2012 is supported by Pradaxa.
Thanks, Dr. Antman. It's a pleasure to present the key results from the DAL outcomes trial, and the title of the presentation is Effects of Cholesterol Ester Transfer Protein Inhibitor Dalcetrapib in Patients with Recent Acute Coronary Syndrome. For decades, observational analyses have told us that higher levels of HDL cholesterol are associated with lower cardiovascular risk. But what has remained uncertain to the present time is whether raising HDL cholesterol therapeutically reduces cardiovascular risk. One of the targets for raising HDL cholesterol is cholesterol ester transfer protein, or CETP, and it's been hypothesized that raising HDL cholesterol by inhibiting CETP might reduce cardiovascular risk. Dalcetrapib was developed as a CETP inhibitor that raises HDL cholesterol by about 30%, did so in phase 2 trials, and did so in phase 2 trials without effect on blood pressure or neurohormones, which were problematic with torcetrapib, a prior CETP inhibitor. So the objective of the DAL outcomes trial was to compare the effects of dalcetrapib with placebo when added to evidence-based background therapy on cardiovascular risk in patients with recent acute coronary syndrome, in other words, very high-risk coronary heart disease patients. In addition to having an acute coronary syndrome, to qualify for this trial, the patients had to have evidence-based management of their LDL cholesterol, which involved statins and diet, but there was no specific statin regimen that was prescribed, nor was there any elimination of patients based on the LDL level that was achieved, and there was no restriction on patients according to their baseline HDL cholesterol levels. This is a schematic of how the trial was designed. The patients were identified at the time of their ACS, acute coronary syndrome event. They spent 4 to 12 weeks in a single-blind placebo run-in period to make sure that their adherence was good and that they met all inclusion criteria for the trial. Then they were randomized, followed in the design of the trial until 1,600 primary endpoint events had occurred, but with 2 pre-specified interim analyses that included analysis for futility. And the trial was conducted in 27 countries in nearly 1,000 sites. The primary outcome measure was a composite of coronary heart disease death, non-fatal myocardial infarction, ischemic stroke, and hospitalization for unstable angina, and cardiac arrest with resuscitation. At the second of the 2 pre-specified interim analyses, when 1,135 primary endpoint events were available for review by the Data Safety Monitoring Board, they recommended that the trial be terminated for futility, and that recommendation was accepted by the sponsor and the steering committee, and the trial was terminated at a point where there was median follow-up of 31 months. The baseline characteristics of the patients are shown here. It's pretty much as expected in an acute coronary syndrome population. Majority of patients were Caucasian and male. Majority had a history of hypertension and metabolic syndrome, and about a quarter had diabetes or were current smokers. These were patients who were very well treated with evidence-based therapies in the background of study treatment. 91% of the patients underwent PCI or bypass surgery for the index event. 97% were treated with aspirin and statins. Nearly 90% with a second antiplatelet agent, nearly 90% with a beta blocker, and nearly 80% with an ACE inhibitor or an ARB. At baseline, at the time of randomization, the mean LDL cholesterol in this population was 76 milligrams per deciliter, HDL 42, triglycerides 134 milligrams per deciliter, again indicating that the control of LDL cholesterol was good in these patients. This slide shows the changes in HDL and LDL cholesterol levels with assigned treatment. You can see that Dalcetrapib increased HDL cholesterol by approximately 30% over the course of the trial and had minimal effect on the levels of LDL cholesterol. So this is an experiment, clinical experiment, that helps to separate out the effects of influencing HDL cholesterol from simultaneous influence on LDL cholesterol. And this slide shows the primary outcome of the trial by treatment group. You can see that there was no effect of Dalcetrapib treatment on the risk of the primary composite endpoint. The hazard ratio was 1.04. It corresponded to a p-value of 0.52. In addition to the neutral effects on the primary composite endpoint shown in the first line of this table, there were neutral effects on every component of the primary endpoint listed below, as well as neutral effects on all-cause mortality and coronary revascularization. So there was no signal, no significant signal of an effect on any of these types of cardiovascular events. So why did Dalcetrapib fail to reduce risk? One explanation is shown in this slide, which plots the annual risk of the primary outcome event on the vertical axis by quintiles of baseline HDL cholesterol on the horizontal axis, shown in black for placebo and red for Dalcetrapib. And the conclusion here is that there was no association between the baseline level of HDL cholesterol and the subsequent risk of these patients. So with that knowledge, it's not surprising, perhaps, that an intervention that raised HDL cholesterol did not influence the cardiovascular risk. Another potential explanation is that Dalcetrapib caused small but significant changes in systolic blood pressure, shown in the top graph, and in C-reactive protein, shown in the bottom graph, both in an apparently adverse direction. So the difference in systolic blood pressure over the course of the study was about 0.6 millimeters mercury, and the difference in C-reactive protein on the right side of the bottom graph, measured after 3 months of assigned treatment, was 0.2 milligrams per liter. So a small difference, but with this many patients, it was highly significant. So to conclude, in patients with recent acute coronary syndrome, Dalcetrapib raised HDL cholesterol by about 30%, had minimal effect on LDL, and had no effect on the risk of major cardiovascular events. HDL did not predict risk in this population, and slightly higher systolic blood pressure and CRP with Dalcetrapib might reflect an adverse effect of inhibiting CETP. And the trial will be available online in the New England Journal tomorrow. Thank you.
Thank you very much, Dr. Schwartz.